Imagine feeling a pressure like you're, what, nearly 100 yards underwater.
Yeah.
That's the kind of intense environment we're talking about with hyperbaric oxygen therapy.
Yeah, it's pretty amazing. And it's not just some extreme experience, it's a serious medical treatment.
Exactly. And today, we're really diving deep into the rules of the road, so to speak, the European Code of Good Practice for hyperbaric oxygen therapy. We're focusing on the latest review from 2022.
Right. And our mission for you today, listening in, is to really unpack these guidelines.
We want to help you understand what keeps this powerful therapy safe and, well, effective.
Cutting through some of the jargon to get to what's truly important for making it work safely.
And the source we're digging into, it's this European Code of Good Practice.
Yeah, it was put together by a working group from Cost Action B14. That's a European research network focused on hyperbaric oxygen therapy.
And it wasn't just them. It's been reviewed, approved, endorsed by the big players. The European Committee for Hyperbaric Medicine, or ECHM, and the European Underwater and Barometrical Society, EUBS.
So this isn't just, one person's opinion. It's a real consensus built on a lot of expert experience.
Definitely. And it's important to remember, this code sets out the minimum requirements, right?
That's key. Think of it as a foundation, a reference point for countries setting up their own specific national rules.
So who does this actually cover?
Well, it's aimed at any medical facility using hyperbaric chambers. That means both the single-person ones, the monoplace chambers.
Like a pod, almost.
Sort of, yeah.
Yeah.
And the bigger multi-place chambers where you can have several people, including staff, inside under pressure.
Okay. And it covers using them for therapy and for research, too.
Correct. And it's thinking about the safety of everyone involved, patients, obviously, but also the staff working there, and even, third parties who might be around the facility.
What is it covering, then?
Good point. It doesn't get into the nitty-gritty of actually making the chambers or designing them or the other medical devices used inside.
Ah, okay. So that's handled elsewhere.
Exactly. There are separate European norms, specific standards that deal with the manufacturing and design side of things.
Got it. So let's talk about this 2022 review. What were the big changes? What did they add?
There were several really significant updates. One of the major ones was formally introducing the role of a safety manager.
A dedicated safety manager.
Yes. Defining their responsibilities clearly, it signals a real push towards a more structured approach to safety, recognizing the unique risks here.
That makes a lot of sense. Dealing with high pressure, pure oxygen, you absolutely need someone focused purely on safety.
Precisely. They also clarified the roles and responsibilities for all the staff. Everyone knows exactly what they're supposed to be doing.
Good. What else?
They brought in a new classification system. It's a way to categorize the chambers, the whole hyperbaric system, the chamber plus all its support gear and even the facilities themselves.
How are they classified? Based on what?
Based on things like their capabilities, what gases they can handle, maximum pressure, and for facilities, whether they can manage intensive care patients inside the chamber.
Interesting. So it helps standardize how we talk about different setups.
Exactly. It gives a clearer picture of what a specific facility can actually handle safely.
Any other key updates?
Yes. There's now specific guidance on having one operator manage multiple chambers at the same time.
Ah, okay. Particularly for those monoplace setups where you might have a few running.
Exactly. And another big thing, the clinical indications. So what conditions HBOT is good for and the contraindications when you shouldn't use it.
Yeah.
They've moved that information right into the main body of the document. It used to be separate.
Oh, that's much more practical. So it's all in one place now for clinicians.
Right. And finally, they added a whole new section, Annex 5.
What's that about?
It focuses specifically on risk assessment for installing monoplace chambers. Since there wasn't a specific Europe-wide standard for them before, this annex provides really crucial guidance.
Okay, that sounds like a really important addition for safety. Let's maybe step back just a tiny bit. Can we quickly define what hyperbaric therapies actually are?
Sure. Basically, hyperbaric therapies are any medical treatments done inside a sealed chamber where the pressure is deliberately increased above normal atmospheric pressure.
Higher than just breathing normal air at sea level.
Right. But when we're talking about this code, the main focus is really on hyperbaric oxygenation, or HBO.
And within that, hyperbaric oxygen therapy, HBOT, how does the code define that specifically?
HBT is defined as breathing oxygen at a pressure higher than 1.5 absolute atmospheres, so 1.5 times normal sea level pressure,
Okay.
for at least 60 minutes. And that 60 minutes doesn't count the time it takes to get up to pressure, the compression, or the time it takes to come back down, the decompression.
Ah, so it's 60 minutes minimum at the treatment pressure, breathing oxygen.
Exactly. The code highlights those three essential bits: breathing oxygen, the increased pressure, and doing it all inside a hyperbaric chamber.
And you mentioned the two main types of chambers earlier, multiplace and monoplace. Just quickly remind us of the difference.
Sure. Multiplace chambers are the bigger ones. They can hold 2 or more people.
Right.
A key thing is they often have separate compartments, like an airlock, so staff can get in and out while the main part stays pressurized.
Which is crucial if you need to attend to a patient during the treatment, I imagine.
Absolutely. Especially for more complex cases.
In monoplace.
That's the single-person unit. Smaller, just for one patient. And the big difference is, once it's pressurized, staff can't get direct physical access to the patient inside.
Got it. The code also talks about hyperbaric chamber systems versus hyperbaric facilities. What's the distinction there?
Think of the system, the HCS, as the core tech. It's the chamber itself, plus all the essential support equipment, the gas supplies, compressors, monitoring instruments, fire suppression, everything needed to make it work.
Okay, the hardware.
Pretty much. And the code actually calls the HCS a medical device under EU rules.
And the facility.
The facility is the bigger picture. It includes the system, yes, but also the building it's in, the staff, the administration, the whole operation.
Right, the entire setup.
Yeah. And the code notes the difference between facilities inside a hospital versus standalone centers. But importantly, every facility needs an area equipped for medical emergencies.
A basic safety net. What about centers for hyperbaric medicine? Is that different again?
Slightly. A center is a type of facility usually linked to or inside a hospital that offers more comprehensive care. They don't just do the HBOT, they handle the patient's overall condition, continuous monitoring, potentially even critical care inside the chamber.
So a higher level of integrated care, usually for sicker patients.
Exactly. The code even suggests classifying these centers based on their ability to handle critical care.
Okay, that makes sense.
Damn.
And just before we move to staffing, what about hyperbaric session versus hyperbaric treatment?
Good distinction. A session is one single dive, one continuous period under pressure for therapy. A treatment is the whole course prescribed by the doctor. It might be just one session, or it could be dozens of sessions over weeks.
Gotcha. Session is one time, treatment is the whole plan. Right, let's talk about the people involved. This sounds like it needs a very specialized team.
Absolutely. The code is clear that the exact team depends on the facility type, the patients they treat, whether they run 204/7, lots of factors.
But there are some essentials.
Yes. Every facility must have a medical director. That's mandatory. And there's a minimum team required during every single session. Plus, everyone needs clearly defined roles.
Okay, let's break down those roles. Medical director, what's their main job?
They have the ultimate responsibility for everything in the center: the equipment, quality assurance, patient follow-up, setting treatment procedures, even research.
So the buck stops with them.
Pretty much. They can delegate tasks, of course, but they remain accountable. It's a critical leadership role.
Makes sense. What about the hyperbaric physician? How's that different?
The physician is more hands-on with the clinical side. They decide if a patient is suitable for HBOT. That's a big part of it, the qualification.
Yep.
They provide the direct medical care during the treatment, maybe even go inside a multi-place chamber for critical cases and handle follow-up. And if it's a 247 facility, you'll need a team of them working shifts.
Right, because they can't just keep going in and out under pressure constantly.
Exactly. There are limits.
What about the hyperbaric nurse?
They're vital for practical patient care, just like in any specialty, but adapted for the hyperbaric environment.
Adapting standard nursing for pressure.
Yes. Applying nursing care for the conditions being treated, assisting inside multi-place chambers, adjusting regular medical techniques.
Mm-hmm.
It's quite specialized. Interestingly, the code notes they might even operate monoplace chambers in some settings.
Huh. So quite a versatile role. Now, that new role you mentioned, the safety manager, what's their focus?
Their job is all about the safety management system, developing it, implementing it, communicating it. They need a really broad understanding, medical, technical, ergonomic safety. They're heavily involved in risk assessment for the whole facility, not just the chamber.
Right, looking beyond just the immediate medical device.
Exactly. They approve procedures, safety guidelines, oversee maintenance programs, incident reporting, audits, and help with staff training. It's a proactive, system-wide safety role, reporting ultimately to the medical director.
So they're the dedicated safety expert for the whole show. How does the hyperbaric supervisor fit in then?
The supervisor is more focused on the day-to-day, immediate safety within the center, ensuring activities are safe right now, overseeing the maintenance of the chamber and the facility itself.
Ah, okay. More operational, hands-on safety.
Right. And the technician doing the actual repairs works under the supervisor's direction.
Got it. And the attendant, the person inside the multi-place chamber with the patients.
Attendants provide direct care inside, but usually non-specialized stuff for stable patients.
Comfort, monitoring.
Yeah, reassurance, basic monitoring. If a patient is critically ill, you'll have a doctor or nurse in there. But for stable patients, the attendant is key. They might do other tasks outside the chamber, too, directed by the nurse or doctor.
Okay. And then there's the person actually driving the chamber operator.
Crucial role. Especially for multi-place chambers, these are complex systems. The operator handles the compression, decompression, controls the gas delivery, enforces safety rules like fire prevention.
Monitors the pressure profiles.
Absolutely. Calculates and monitors the pressure schedules for everyone inside, manages decompression stops if needed. They might even do basic checks on equipment inside the chamber, make sure patient devices are safe to use under pressure, and they oversee the compressors, gas banks, basic maintenance.
Wow. That definitely sounds like it needs very specific, intense training.
It really does. Highly skilled.
So what's the absolute minimum team needed during a session?
For a multi-place chamber, you need at least 3 people present, a hyperbaric physician for medical supervision, an attendant inside with patients, and an operator running the chamber.
Always those 3.
Minimum. The actual team size depends on a risk assessment, how many patients, how sick they are, and critically, one operator can only manage one hyperbaric system at a time.
Even if it's a system with multiple link chambers.
Yes. And there are patient-to-attendant ratios.
Ratios?
Yeah, like max 12, 15 stable patients per attendant. Fewer if they're unstable, maybe 5 or 6. And only 1 or 2 intensive care patients per attendant.
That makes sense for ensuring proper care. What about monoplay sessions?
Minimum team there is 2. A hyperbaric physician and an operator.
And can one operator handle multiple monoplace chambers?
Yes, the code allows it, but only if they're all in the same room and the operator can safely supervise them all.
Same kind of ratios apply.
Yes. Max 3 stable patients per operator, 2 demanding ones, or 1 intensive care patient. And in all cases, the whole team has to stay in the facility and be immediately available the entire time.
Right. And finally, for staff, you mentioned fitness and health checks are really important.
Hugely important. Working under pressure has unique occupational risks.
Like what?
Well, things like decompression sickness, barotrauma. So anyone working in that environment needs initial and regular medical exams to make sure they're fit.
Okay.
Daily fitness matters too. Can't go in if you're unwell. Any pressure-related health issues have to be reported, and you need clearance to return.
And procedures for decompression.
Absolutely. Facilities need published decompression procedures for staff to minimize risks, especially with repeated exposures. And crucially, they need clear practice procedures for recompressing an attendant immediately if they suspect decompression illness.
Wow.
Plus, staff need to know about restrictions after exposure limits on flying, diving, going to altitude for a period.
It's a very thorough approach to keeping the staff safe, too.
Okay, let's switch gears to the hardware, the equipment, and keeping it maintained.
Right. For the big multi-place chambers, the code is very clear. They must comply with a European standard called EN 14931.
EN 14931, what does that cover?
Basically everything about building and equipping them safely, materials, safety interlocks, fire systems. It ensures a consistent, high safety level for those chambers across Europe. So, facilities using them meet a tough standard.
And for the monoplace chambers, where there wasn't a specific standard until Annex 5.
Exactly. Until a full standard exists, the code puts the responsibility for a detailed risk assessment on the facility's medical director.
But they recommend following Annex 5.
Strongly recommend it. Annex 5 outlines the minimum safety requirements they should aim for. The basic safety ideas are the same for both types, even if some technical details differ.
What about other medical gear used inside the chamber? Those devices also need to comply with recommendations in EN 14931, specifically Annex B. And anything else brought in, even if not a medical device, has to be checked and certified as safe for the hyperbaric environment, up to the max pressure.
Basically, nothing goes in unless it's been specifically approved for pressure and oxygen.
That's the core principle. Can't introduce new risks.
And keeping all this gear working, maintenance must be key.
Absolutely critical. The code demands meticulous maintenance, following the manufacturer's instructions precisely. Regular checks, servicing, prompt repairs. It's fundamental to safety.
And cleanliness, hygiene in these chambers.
Also vital. They need thorough cleaning and disinfection between every single patient session.
With special cleaners?
Using broad-spectrum disinfectants that are effective but also compatible with the chamber materials, you don't want to damage anything.
Right.
And for things like flu season or pandemics, the code suggests considering closed UV air cleaning systems between sessions while being careful not to damage any PVC windows.
A layered approach to hygiene. What about the gases they use? Oxygen, air.
Quality is paramount there. Any gas breathed by the patient has to meet the strict standards of the European Pharmacopoeia.
Checking for impurities.
Yes, because impurities can become more toxic under pressure. And for gases not listed there, like helium sometimes, they need to meet at least the standards for professional diving gases.
And the air used just to pressurize the chamber.
That medical air needs to meet another standard, EN 11221. Quality control is essential for all gases involved.
And they need enough of it, right, for the treatment in emergencies.
Exactly. The code references EN 14931 again for gas quantity specifications, ensuring they have sufficient supply for planned treatments and any unexpected issues.
Okay, equipment, gases. Now let's talk risk management. This feels like a huge part of the code.
It absolutely is. It's defined as a systematic, ongoing process, analyzing, evaluating, controlling all potential risks.
And it's not just the manufacturer's job.
No. While the maker assesses risks in design, the code stresses that every single facility must do its own comprehensive risk management for its specific activities.
So you can't just copy someone else's assessment.
Definitely not. Each facility has to analyze its unique situation, its equipment, its patients, its procedures, and reduce risks to an acceptable level.
What does that process involve?
It involves identifying the intended use and potential hazards, estimating how likely and severe those risks are, putting controls in place, and then constantly checking if those controls are working and the remaining risk is acceptable. It's a continuous cycle.
What kind of hazards are we talking about generally?
The code lists broad categories: physical energy like pressure, biological like infection, environmental hazards, risks from incorrect outputs like wrong gas mix, user interface issues, equipment failures, the usual suspects in medical tech.
And then there are specific hyperbaric hazards.
Yes, and some are quite unique. Pressure itself, risk of explosion, loss of containment, gas supply issues, interruption, contamination, oxygen hazards, fire risk, toxicity, electrical safety inside, prohibited materials.
Yes, the prohibited materials. You mentioned some surprising ones before, like aftershave, newspapers.
Exactly. Annex 4 lists them. Aftershave is flammable due to alcohol. Newspapers, combustible, static risk maybe. Also banned are aerosols, unprotected batteries, non-approved cleaners, tobacco, matches, lighters, petroleum lubes, even powdered sugar.
Powdered sugar, wow.
Flammable dust, potentially. Thermos flasks, too, implosion risk. And clothing is a big one. Synthetics, wool, anything contaminated or flammable is out. 100% cotton or certified hyperbaric compatible materials are strongly recommended.
It really drives home how different that environment is. What about oxygen toxicity risks?
That's a major concern, both cerebral causing convulsions and pulmonary, affecting the lungs.
Convulsion?
Yes, the risk is higher in patients with fever, low blood sugar, high CO2, certain brain conditions, or taking certain drugs. Facilities need clear procedures for handling an oxygen-induced seizure safely.
And lung toxicity.
That's more a concern for patients getting lots of treatments or staff breathing oxygen for long periods. It has to be factored into treatment planning.
And fire safety, obviously huge with all that oxygen.
Paramount. While actual fires are rare if rules are followed, the consequences are catastrophic because things burn so fast and hot in high oxygen.
So prevention is everything.
Absolutely. Rigorously excluding flammable items and ignition sources. Multi-place chambers have detailed fire system requirements in EN 15931, but every facility needs its own written fire emergency plan prevention, action during a fire, inside or outside the chamber, and crucially, patient evacuation, especially for those who can't move themselves. Regular drills are essential.
Makes sense. What about dysbaric injuries, pressure-related injuries?
Patients breathing oxygen are mainly at risk for barotrauma ear squeeze, sinus squeeze, but less risk of decompression sickness.
But the staff inside?
Attendants breathing compressed air are at higher risk for all dysbaric injuries, especially decompression sickness, with repeated entries. So they need training to recognize symptoms and know prevention methods. And facilities must have procedures for immediate recompression treatment for staff if needed.
Immediate recompression on-site.
Yes, readily available. Plus awareness of those post-exposure restrictions on flying, diving, etc.
And quickly, manual handling and thermal stress.
Moving patients, especially non-ambulatory ones, into chambers without walk-in doors carries musculoskeletal risks for staff. The code pushes for using hoists and handling aids based on risk assessment.
Okay.
And thermal stress procedures must ensure the chamber stays within comfortable temperature limits, not too hot or cold, following guidance in EN 14931.
It's clear safety is embedded everywhere. Let's talk about the actual procedures for running the therapy.
Right. The code says manufacturers provide the initial info for safe use, but the facility, the employer, has the responsibility for managing hazards in their operation.
So each place needs its own playbook.
Exactly. A comprehensive operating manual detailing all standard work practices for everything they do.
Tailored to their specific setup.
Yes. It needs to cover routine standard operating procedures, SOPs, emergency operating procedures, EOPs, contingency plans guiding everyone, medical, technical, admin. The manufacturer's manual is a key part, but the facility builds on that. Annex 1 gives a framework for what should be in it.
And it's a living document. Needs updates.
Definitely. Reviewed periodically, updated when things change, and everyone needs to know the parts relevant to their job and have easy access to the current manual.
What key things do the SOPs need to cover?
Chamber operation, the specific treatment protocols they use, contingency plans for foreseeable emergencies, also patient management, how they handle admission, preparation, the treatment itself, discharge, team responsibilities, record keeping. It's comprehensive.
And the clinical assessment part.
Yes. The medical director is responsible for assessing the individual risks and benefits for each patient, considering their specific conditions. Annex 3 points out areas needing special attention there.
And when things go wrong, the emergency operating procedures, or EOPs.
Right. Facilities either adopt the hospital's general emergency plans or develop their own specific ones. Emergencies, medical ones with the patient, or system failures with the equipment are always possible, and the pressure complicates things.
So they need planned responses.
Absolutely. Detailed step-by-step procedures for various scenarios integrated with any wider hospital plans. And crucially, these EOPs must be practiced regularly through drills so the team can respond effectively. Annex 4 highlights areas for focus here.
And maintenance procedures, keeping logs.
Vital. Each facility must keep the system safe and operational. That means a detailed maintenance register based on manufacturer instructions.
Recording everything.
Everything. What was done when inspections, certifications, parts replaced, technical incidents, breakdowns, corrective actions. It's all about tracking performance and safety.
Record keeping in general seems like a big procedural theme.
It really is. Health and safety data, technical logs, clinical operations, patient treatments all need careful recording. The code specifies 3 levels. Facility records, staff training, duty rosters, exposure logs. System records, session logs with pressures, times, gas used, checks, disinfection, maintenance, incidents, and patient records. ID, consent, history, diagnosis, treatment plan, session details. Annex 2 details the minimum needed for these logs.
And all this procedure aims at patient safety. What specific patient safety points does the code emphasize?
The SOPs have to cover the whole patient journey reception, pre-treatment assessment, the session, discharge.
Assessment by the physician?
Yes, including a full history. The 2022 review highlighted things like needing an adult companion, who also needs assessment and consent for young children, and special handling for ICU patients, transport, in-chamber monitoring, maybe even procedures inside the chamber.
And tracking problems.
Critically important. Any deviation from SOPs, any adverse effect, complication, or aborted treatment must be documented, registered, and analyzed. It's part of continuous quality control. Annexes 3 and 4 have more on patient management details.
Okay, so we know how to treat safely. Now, the big question, when should HBOT be used? What are the approved conditions?
This is crucial. The code says every facility must adopt a specific list of clinical indications they treat as standard.
Based on what?
It has to align with local national regulations, healthcare standards, and be approved by hospital authorities. The code strongly recommends using the list from the European Committee for Hyperbaric Medicine, ECHM.
Why their list?
Because the ECHM list is internationally recognized and rigorously based on evidence-based medicine and expert consensus. It's the go-to reference.
So there's a standard list of conditions where HBOT is proven effective. What about using it for conditions not on that list, off-label use?
The code allows for that, but only in 2 very specific situations.
Which are?
Either as part of a formal, ethically approved clinical research trial, or under what's called compassionate use.
Compassionate use. What does that mean here?
It means there has to be a plausible scientific reason to think HBOT might help, even if it's not proven yet. And the patient, their doctor, and any payer must be fully informed about the risks and uncertain benefits and all agree to try it.
Fully informed consent is key.
Absolutely. And importantly, if it's done under compassionate use, the code says it should be at no cost to the patient. It provides a controlled way to explore potential new uses ethically.
That seems very responsible. What about the flip side, contraindications? When should you not use HBOT?
This is interesting. The code actually states there are virtually no absolute contraindications.
Really?
None at all. Well, it reflects the idea that in some critical situations, the potential life-saving benefit of HBOT might outweigh the risks of a condition usually considered a no-go.
Ah, okay. So it's always a risk-benefit calculation.
Exactly. If a patient has a condition normally seen as a relative contraindication, the code demands an especially careful individual benefit-risk assessment before proceeding.
Taking what into account?
The patient's specific condition, the staff's experience, the facility's equipment capabilities. It's always an individualized clinical judgment.
Okay, so very patient-specific.
Ah.
Lastly, the code mentions accreditation.
Yes, it strongly recommends that facilities seek specific accreditation for hyperbaric operations.
From a recognized body.
Ideally, yes. If a local option isn't available, they should at least get some form of external validation of their equipment and procedures. It's about ensuring consistent quality and safety across the board.
This has been incredibly thorough. If you had to boil it down, what are the absolute key takeaways for our listener?
I'd say the European Code provides this really solid, detailed roadmap for safe and effective HBOT. The core message is about having well-trained staff, properly maintained gear, robust risk management tailored to the unique environment, and sticking to clear procedures for both routine operations and emergencies.
And clarity on when to use it.
Yes, clear guidance on evidence-based indications and that very careful, individualized approach to potential contraindications. It's really a blueprint for quality and safety in this field.
So for anyone listening, whether you're just intrigued by this therapy or it might be relevant to your health, hopefully you now have a much clearer picture of the high standards underpinning it all.
Exactly. And, it does make you think.
Yeah.
Considering how detailed these international guidelines are for hyperbaric medicine, focused so intensely on safety and quality, what other areas of medicine could really benefit from this kind of rigorous standardization and collaborative expert oversight?
That's a great question. Where else could this level of shared best practice make a real difference to patient safety and outcomes? Something definitely worth pondering.